Can get started. Okay, just give me a second here. So, good day, everyone. So we're very excited that you could join us today. Today we are very honored to have Professor Richard Levinson, who will be giving the invited lecture today on how we can use AI and digital tools in pathology, and particularly, very interestingly, thinking about glassless pathology, which is really fascinating. And so I'll just do a brief introduction. Professor Richard is a professor in the Department of Pathology and Laboratory Medicine in UC Davis Health. He received his MD at the University of Michigan and pathology training at Washington University, followed by a cancer research fellowship at University of Rochester and faculty positions at Duke and Carnegie Mellon. He then joined Cambridge Research and Instrumentation, INC, becoming the Vice President of Research before assuming his present position at UC Davis. He helped develop multispectral microscopy and small animal imaging systems, birefringence microscopy, multiplexed ion beam imaging, and slide-free, as well as enhanced content microscopy approaches. He is also an inventor of some 15 patents. Since joining UC Davis, he has co-founded 3 startup companies. This is really critical, and congratulations on this. He is a section editor for Archives of Pathology and is on the editorial board of Lab, Invest, and AGP, and is currently the director of the DPA. He jokes that regrettably he has taught Pingens histopathology and radiology, and he is the recipient of the 2018 UC Davis Chancellor's Innovator of the Year Award. And also he's a fellow of the SPIE. So obviously a long list of accomplishments, Professor Richard, that we cannot go through all of that today, but we are so honored to have you give this lecture. And just to add that, we're very excited that you are bringing this. You're not only an inventor, but you're trying to bring some of these innovations to low and middle income countries for global health, in particularly working with my sister Beatrice in Ghana, which I think is really going to have a big impact. So thank you again so much for joining. I'm just going to hand over to you to go ahead. Typically, the lectures, start with you giving the lecture, and then you can run this as you like. There'll be questions that come into the chat, and at the end, we can ask those questions so that you can have a discussion with the audience. Thank you so much.
Thank you. I'm really honored by this invitation, and I look forward to discussing a really unappreciated area of medicine, which is pathology. Typically, at least in this country, very often, if a patient has a specimen or a tissue specimen or a blood specimen, what happens is that the phrasing is, we sent it to the lab and they said this. And no one knows what the lab is or where the lab is or the centrality of actually diagnostics to the rest of medicine. And that's here at UC Davis. And I think in the rest of the world, it may be even less appreciated what pathology is or does or the role it plays. And so I wanted to touch on that and also on what we were attempting to do with our novel approaches to pathology, which, as I will explain, is a very old and innovative discipline until just recently. So let me see if I can share my screen. Will, can you let me share? Okay, let's try this again. I'll give my whole desktop, and then we'll go to see if this works. It's always a thrill. Okay, so checking with you all. That's not what I meant to do. Okay, how does that look?
Looks fantastic. We can see it.
Fantastic. Okay, wonderful. So the title is obviously New Technologies for Global Health Tissue Diagnostics. And the people who have contributed the most to this process is myself, my colleague who worked with me for 10 years at UC Davis before he left to go to become an associate professor at Emory, Farzad Faradouni, my colleague at University of Washington, who's been helping develop and build the instrumentation that actually got shipped to Ghana, and of course our wonderful Ghana co-principal investigator, Beatrice Wafiadai, who kindly introduced me to this organization and is helping move this forward in many areas. So, and that image there might be a little baffling, but what I'm trying to show is that, we're trying to get rid of the glass slide because that's one of the major drawbacks in histology and pathology. And so this is showing you that you can enjoy life without glass. So let's see if I'm having difficulties. Let's see. Let's try one more time. It's not advancing. Annotate, so I have to turn off annotation. I think that's what is problematic. Let me restart this if you don't mind. I will stop sharing and I will stop the slideshow and see if we can't regroup. So start share. You'd think that the former vice chair of strategic technology should be able to manage a PowerPoint, but you never know. Okay, so I do have disclosures. As you already heard, we founded a couple of companies out of my lab here at Davis. And as I'll show you at the end, Muse microscopy has developed from just being a exciting startup to actually being really implemented in the real world, which is very, very intriguing. So as I mentioned before, pathology is really the underappreciated center of medicine. There's a famous sort of statistic that says that 70% of what happens in medicine is actually mediated in one way or another through pathology, either through the laboratories where you do the various blood tests, or through what we're talking about today, tissue diagnostics, which really tells you whether the mass that the patient has presented with is a horrible cancer or just a benign swelling that will go away if you don't have to worry about it. It is really essential to the success of patient treatment. And I'm going to be talking about really the core of modern medical understanding, which derived through the late Middle Ages and early modern era from skilled investigators who finally got past ancient Greek and Roman understanding to actually learn by observation what was going on in the patient. And the autopsy was really the keystone of modern medicine. And just to reassure you, this picture is not a real autopsy. It was actually an anatomy lesson. And so this is how people learned that what was inside the body was really helping define what was happening to the patient. And then you began to look at not just sort of whole organs, but looking at organs in more detail to see if they could correlate what they saw here with what was going on with the patient. And remarkably, even though this looks like a photograph, it's actually an oil painting of slices of brain. And if there had been a brain tumor, you would be able to see a structure that didn't belong there. And but just seeing lumps isn't enough. So you really, the core of what we're talking about today and of pathology in general is microscopy. And the point is that you can have a structure that you can see very clearly by eye, but it's still not clear what it is. And I'll give you all a quick quiz. This is obviously something in two halves, left and right. Where's the lesion? And a good third of people I asked said lesion's on the left. It looks ugly and bloody. Well, no, actually, that's normal adrenal. The mass on the right is the tumor. But having said that, we don't really know whether it's just a benign growth or something that will continue to grow and kill the patient. And for that, we have to do microscopy. That's at least the truth now. Things are changing with molecular biology and other techniques, but right now, microscopy is central. And what we do, pathologists, is look at images like this. And what's going on here is that we're actually at obviously the microscopic scale where we're looking at individual cells and their relationship to one another. The little blue things are nuclei, the pink stuff is cytoplasm. There's a lot of fat down here because it's cleared out. You can actually make some decisions about what it is by looking at it at this scale. And now I will teach you in 2 slides to be all of you to be pathologists. So this is what we look at as another example. This is, as you can tell, normal prostate. And how do we know it's normal? And the central and the circular answer is because it looks normal. That's what we do. We look to see if these things resemble what we were taught to represent either normal structures or abnormal malignant or pathological deviations. And so what we see here is things doing stuff. This out here is the connective tissue and muscle in a prostate. Here are the cells that are actually making prostatic fluid. This is a prostatic secretion from the fluid. It all looks good. In contrast, here is adenocarcinoma of the prostate. And again, if we look closely, the nuclei look fine. They're little and round and more or less the same size. But if you check, there's really no structure that makes any sense. It's just a fairly uncontrolled growth of cells. This is cancer. It's not doing any good for the patient, and if not treated, may go on metastasize to the brain or the bone or other tissues, liver, and kill the patient in a few years or decades. And that's another thing that pathologists can do is they can first make a diagnosis and say this is cancer, but then they can say, and it's a bad kind or it's a good kind, it will kill the patient quickly, or it will last a long time. And oh, by the way, because of the shapes and structures, you can treat it with this drug or this drug or this drug, or surgery, or radiation. So I'm going to be focusing, at least conceptually, on breast and how we approach breast tumors, which is the focus of our collaborator, Dr. Rafia Dai. And there are differences in how we approach patients with either known or unknown lesions in the breast in various countries, and the well-resourced nations do things differently than what happens in low and middle income countries. But there are really, we're talking about tissue aberrations, there are really 3 ways of approaching, or 4 ways really, of approaching a potential breast lesion. The first is by screening. In other words, women who are otherwise not known to have a breast problem undergo mass mammograms or even just manual tissue exams, manual exams of the breast periodically, hoping to catch a lesion early in the course and so potentially be able to do curative therapy. What is more often the case, especially in countries like Ghana, is that women do not have access to screening procedures, and because of various social pressures, may not present to the medical system until a breast mass is really quite far along. But given that there is a mass, how do you approach it to try to actually give tissue to the pathologist and So they're really in the breast. There are three ways of looking at this. Something on the far left is called fine needle aspiration. That fine needle means a very, very small needle. And it's so small that it doesn't actually pull up whole chunks of tissue, but it pulls up isolated cells and little tiny cell chunks and clusters. In the middle is what we're going to be focusing on today, which is core needle biopsy. So it's still a needle, but it's big enough that when it goes into the target, that can be breast or liver or kidney or prostate, it takes out a chunk of tissue that is big enough that you can actually see tissue structure. And the difference is on the left, the method of looking at the specimen is called cytology, which means the sort of looking at cells. And the one in the middle and the far right is histology, where you're looking at tissues more or less intact. And of course, on the far right, you can see a scalpel, and that's what was done until the advent of core needle biopsies. That's where you actually had to go in, open up the patient with a small incision or large incision, and actually cut out a chunk to be examined. None of these are what I would like to have to myself, but it's better than dying from breast cancer. So just an example of fine needle aspiration. This is showing obviously a breast, and the optional image of an ultrasound probe, which can help guide the proceduralist, as they sometimes called here, to actually get the needle into the right spot. And that's by no means easy. It's a major challenge to make sure that you hit the lesion, because they can be very small and relatively deep and hard to feel. And then what happens is, I said, the needle is so fine that you don't see tissue clumps like I showed you previously when I trained you to become pathologists. You just see isolated cells. The cells can be very definitely abnormal. You can see in the sort of middle of the image on the right. I don't know if you can see my cursor or not. But there's a cell that's got a much larger nucleus, or a purple thing, than other cells around. So this is not a good looking cytology smear, but I think you can appreciate that an awful lot of the information that I showed you before, how tissue is organized, whether it's in a functional structure or not, is lost. We're looking just at a cell by cell level. And so it's the consensus, at least in this country, that fine needle aspiration is not the ideal technique for looking at breast lesions, except certain specific types, and that at least a core needle is where we want to go. And so that's shown, sort of an example of this in its components. It's shown here on the top left is a very, very simple depiction of a core needle biopsy instrument, and they can be much more complicated than that. Vacuum assisted, have lots of strong springs and different controls on them. But the essence is that there's a needle, and that it goes in, and then by virtue of sliding, there's a sort of notch here. This is one version of it. And by then shooting this little sharp part over this open area, it creates a core, a full core of the tissue shown down here. So this is a core of breasts, perhaps, sitting in the needle. And then what happens is that it's taken out of the needle, either gently by hand or through other methods, and entered into the pathology process, which I'll describe in a second. And what you see on the top right is 4 of these needles that are sitting on a glass slide, having been processed. And you can zoom in and even zoom in further if you wanted to. And you can see that this is not normal breast. It's in fact lobular carcinoma of the breast. And so a diagnosis, and really a quite well configured diagnosis, can be arrived at just from these core needles. And in fact, the story, of course, doesn't stop there. I won't talk about it in any detail, but the next steps often involve doing what's called immunohistochemistry, where we look for molecular markers Typically in breast these days, it's things called HER2, ER, and PR, which are ER is estrogen receptor, PR is progesterone receptor, HER2 is something to do with, excuse me, the sort of growth factor environment and responsivity of the breast. And these molecular markers can also help define what kind of A, what the prognosis is, B, how the patient should be treated. So that's how we now get core needle biopsies. This is what Dr. Oyafi Adai does in her practice. But then that's only the beginning, and that's where the problems really start. Because the next step, as I've already shown you, is of a pathologist who's reviewing the slide. And that's the state of the art. You can see this nice sort of modern looking environment with a computer screen up top left, a blue camera sitting on top of the microscope. But things really haven't changed for a long time in this way of doing pathology. And I'll show you that in the next series of slides. So now that's in contrast to what's happened in other medical disciplines. Surgery has progressed a great deal. As you can see here, this was surgery before anesthesia, and it's not something that I would like to be part of on either side of the procedure. A few centuries after that, we have things that look like these. These are the Da Vinci brand surgical robots in a unnaturally clean operating suite. So the surgeon is driving the robot, but the patient and the robot is on the far right. Huge difference from what you see on the left panel. Let's compare that with pathology. So, obviously the core to modern pathology is microscopy, and the unappreciated secret is that the microscope itself has not has not varied in its core design since the late 1600s, the 17th century. And this was really brought to its then level of perfection by van Leeuwenhoek, who made that microscope, which is shown on the top left. And some modern models of that have been built, and then imaging through it have been tested. And what you can see in the middle and bottom right is that microscope on the top left still has sufficient resolution to actually see down to the level of single red blood cells, and there's a white blood cell. And the only thing it's missing is that he did not use, and for hundreds of years, people did not use special stains, like I'll describe, to actually bring out more contrast and make it clearer. But if that's the only microscope we had, and if you added the stains of hematoxin and eosin, we could probably do most of what we do as pathologists with that very, very old device. So let's talk about, so that's the microscopy, but you can't just take a piece of tissue and look at it under a microscope. You have to do a lot of work to go from the biopsy, and I'm showing you that we're not quite state of the art here at Davis. That's how we do it here. Hint, that was a joke. After you remove the piece of tissue, there are lots of steps, which I will describe in more detail here, but I'll show you just in sort of a high-level form. The tissue has to first go, typically, this is typical, into a formaldehyde to actually preserve it. Then it has to get embedded in wax so that it can be cut. And we need these thin slices because you can't look at a thick piece of tissue with von Leeuwenhoek's microscope. So these are thin slices being prepared on the middle left panel, and then they get floated in a water bath and floated onto a glass slide, and then they get stained, and then they get put onto, the slides get rinsed off and cleaned up and labeled, and finally that slide gets delivered to the pathologist and or the digital scanner. So in UC Davis, it's hours overnight typically. In other institutions, especially if there's a lot of backlog in the lab, or if the lab is not next to where the procedure took place, the tissue has to be delivered to the laboratory, which could take, just a taxi ride across town, or weeks of traveling. And so there's a huge delay just in the logistics of all of this. So let me just bring home sort of the complexity and the requirements and why this is not easy. This is the tissues. Here's a sort of a smallish tissue lab. And what happens is those little bottles on the left are pieces of tissue sitting in formaldehyde, typically. Big chunks, that might be a whole kidney in that bucket there, and little tiny biopsies. And then those have to then get processed into wax and cut. And so but first they have to be sliced and cut into just the right sizes and shapes to be processed further. That's a process called grossing. And then here is after grossing, you look at it, and if it's small, you can simply immediately put it into a histology cassette, which is what's being held on the top there. That's really crucial because it has the patient's or the specimen number on it, and it's got little holes in it to allow solutions to flow in and around those little tiny pieces of tissue. And then they have to be processed, and typically in most settings, you have a machine to handle all of the solvents and the heating and cooling and impregnating with wax. And at the end of all of that, you end up with something that you can see on the right here. Those are pieces of tissue, very hard to see, embedded in paraffin wax. And that's the substance that will hold things still and undeforming when the cutting takes place. And here you can see somebody actually cutting the specimen. It's shown there in the middle, that brown stuff in the white box. And then every turn of the crank makes another 5 micron or so slice. They're still in wax, but they get put onto a slide. And then they get, you have to get rid of the wax. You have to be put into, and I didn't tell you that it had to go through ethanol to xylene to wax. And now it has to go from wax to xylene to ethanol to aqueous. And then it goes typically in a motorized machine like this, which takes the slides, which are those little white squares at the top right, and they get dunked one after the other into those baths until finally, and washed at the end until finally they have the blue stain, which is hematoxin, which is for the nuclei, and the pink stain, which is eosin, which is for everything else. And finally you get a slide. And as I mentioned, there are lots and lots of, not just all the personnel involved and the skilled personnel, and also all of the equipment, but you need lots of solvents and reagents and stains. And these are toxic and very bad smelling. And I do remember going into a lab in Nepal and just being appalled by how badly it smelled and really how toxic the atmosphere was from all of these really obnoxious chemicals. So, as you can see, outside of well-equipped medical centers, it's very possible, because of all of the obstacles that I described to you, that you will encounter substantial delays in obtaining pathology results. And by substantial delays, I don't mean just hours or days or weeks, but actually months or perhaps never, depending on where the patient is, where the histology is, where the surgeon is. So this is a major, major challenge. And according to Beatrice, my colleague, sometimes as many as 30 to 40% of patients who actually present and are biopsied fail to get properly entered into the medical system because of delays in pathology. And they are lost to follow until the disease maybe progresses even further. So what are the impact of pathology delays? I think it's sort of obvious. The obvious one is there's a delayed diagnosis, and most people don't really want to treat until they know that what they're treating is what they think it is. And even if you look at large lesions in the breast, it may be fairly obviously cancer, but some lesions are masses, but they're not cancer. They're tuberculous mastitis, for example, other infectious diseases. And so mistreating those would really be catastrophic. And if you don't have a diagnosis, you just take a guess. That's what I mean here by empirical treatment, and you treat with whatever you think the patient needs. You might be right, you're probably right, but you may be wrong. And obviously the impact on the patient is diagnosis and mistreatment, and unnecessary or premature death. So that's pathology today. And the question is, how are we as a field addressing some of these problems, which have been, sort of not been acknowledged for the last 200 or 300 years, but people are now realizing that this really does represent pathology, and histology represents a bottleneck in patient care. And also extra cost, because if a patient, for example, comes into a hospital and is biopsied, they may stay around for 2 or 3 days waiting for the diagnosis. Nothing is being done, costs are going up, or they have to go home and come back. Lots of costs, lots of inefficiency. So there are now multiple techniques, optical techniques being developed to really address the problem of why do we have to wait so long to make a slide and read it. And I'm not going to describe these in any detail. I'll just list them as new techniques, which are really in their own way making major advances. Confocal microscopy, and it's a sort of similar technique called multi-photon microscopy. And then a completely different technique called optical coherence tomography, which is that. Structured illumination, which is a different way of achieving thin sectioning on thick tissue by actually using light that's shaped in some way to define a certain plane of vision. Light sheet microscopy, which is actually a way of getting three-dimensional images. So, for example, in prostate, it's apparent or believed that the shape of the prostatic glands, benign and malignant, really are best appreciated in 3 dimensions, not on just thin sections. And then another very orthogonal way of doing things called photoacoustic imaging. These are all remarkable and can generate some really beautiful images, but they do have some certain issues with them. For one thing, they can be very expensive. They can require fancy lasers, computation. They may generate images that are not familiar and may require a computer-assisted diagnosis. And they're not, they're not something that you could run around in a van and go from village to village with. They're fairly physically tender boxes that require care and feeding. So, here's a plug for a paper that I helped write last year on describing all of these and others, I think. So what do we really need? If you had to design it from scratch, well, you don't want the microscope in the top left, all that complex instrumentation. That's not a microscope. I don't know what it is, but you don't want something that complicated. You don't want something that requires bars of gold to purchase. And you want it to be friendly, and there's my image of a friendly pathologist, but it wants to be pathologist friendly so that there's not an intellectual obstacle between the images and what pathologists have been trained on, and it wants to be somehow suitable for global dissemination. So I think that's something that we've been approaching and describe further for you. So I'm going to describe 2 very, very similar techniques. One is called MUSE and the other is called FIBI. And MUSE, the acronym is very descriptive. It stands for microscopy with UV surface excitation. So it's a microscope. It uses ultraviolet light instead of regular light in the regular visible range to excite or to illuminate the specimen, but the signals that come off the specimen are in the normal visible range. They can be collected with a normal microscope objective, like a 10x or 20x lens, and they can be transmitted to a standard, relatively inexpensive color camera. And the reason it's called surface imaging is that what I'm showing you here up in the green is a specimen. As you can see, it's not a thin slide. It's a thick chunk, and by thick, I mean it can be millimeters or even centimeters thick, because all we're looking at is just this surface right here that's sitting on the UV window. And UV window sounds exotic, but it's just a piece of sapphire or quartz, something like that. And that's because the LED light that we use is of a wavelength that doesn't go through normal glass. And the images are generated immediately. The tissue is stained very, very quickly with a simple dye combination of DAPI and rhodamine. On the left is a standard H&E. When I say H&E, I mean hematoxin and eosin. I've shown you that before. Images. And on the left is an equivalent Muse image, which can, and I don't think I show this in this talk, can be converted with very simple computational techniques, so that the light blue nuclei here are turned dark blue, and the sort of orangey greenish stuff on everywhere else is turned into pink. So it can be made to look just like H&E. But the left took at least overnight, if not weeks, to generate. The right took just a minute or so from the tissue to the image. And the images are gorgeous. This is just a picture of kidney, showing that because it's a color camera, unlike some of the other techniques that I showed you before, we actually get a full range of colors. That's a blood vessel. And because it's a thick piece of tissue, you can see down into the blood vessel. So you can actually see it's a three-dimensional object. The blue stuff is collagen. The orange stuff is elastic laminae in the artery. These are all important structures. The other stuff are various kidney tubules. And just to show you, this is even not full resolution that's achievable, but you can see the elastic laminae. You can see the endothelial cells on the inside of the blood vessel. And so there's just a lot of information there that I think is more informative than standard H&E. Here's another pretty blood vessel and kidney. The blue stuff is collagen. The yellow is the elastic laminae. But because it's intact chunks of tissue, you can see intact structures. So these are blood vessels coursing through an intact piece of breast. And again, you wouldn't see anything with this degree of sort of understandable surface information on a very, very thin slide. And I'll show that a little bit more later. Piece of skin. The yellow stuff is elastin, the blue stuff is collagen, and that thing in the middle, we haven't sort of pursued this. This was a chance finding, but that's a fungal organism that probably grew in the specimen after acquisition. But it shows you that what we can see that's really quite informative, and I'm sure that's more easy to identify than a simple 5-micron slice through a little bit of that structure in the middle. And you can even do this, and this is potentially relevant to global health. You can even develop it on a cell phone, on iPhone. This was done by my colleagues at Case Western Reserve. And so Yeehee, very, very inventive young man, figured out that the entire microscope is shown on that little blue box on the far right. That's just sitting over the iPhone camera outlet. And it's actually powered by the iPhone itself. You don't even need external power supply. And the images are remarkable. And I'll just show you. And so all of that can be manufactured for $20 plus the cost of a phone, which is a few $100s. So just with that, you can have a microscope that fits in your pocket. And the images are quite remarkable just without any optimization. I'm showing you on the left mouse kidney. On the right, mouse liver. It's not, it's not at high power, but it's enough to see a lot of what's going on. And you can look at surfaces of things. That's the outside of the intestine. This is, and then on the right is a sort of semi 3D understanding of what the inside of a testis looks like. Again, just with that handheld little microscope. But that technology has also been evolved into a full-fledged company just in the last year or so, now called Muse Microscopy, Inc. And they, on the very far right, you can see one of their prototype boxes. So it's small and, sort of easily portable and deployable. And they were platinum sponsor at a major US pathology meeting earlier this year. I'll finish with a slide from their presentation at ASCO, which is another cancer meeting again this year. Well, after we developed Muse, we also developed FIBI, which stands for fluorescence imitating bright field imaging. And the difference here is that the images don't look like fluorescence. They look just like what the pathologists are used to seeing directly into the camera. So you don't have to do sort of necessarily any fancy math. I won't go into the details, but the simplicity is about the same. You just have an LED illuminating it. Here's a standard microscope objective. Here's a thick piece of tissue. Here's the color camera, little box on the left, just an early prototype, and an image like this on the right, which is what the camera saw, no math required, and that's a normal breast lobule. And how it works a little bit, the tissue does need to be stained, but it's actually stained with hematoxin and eosin. So there's a piece of tissue that had no stain and was being imaged. You don't see anything. If you stain it with hematoxin, suddenly the details begin to appear. And if you throw in the eosin, you begin to see more details in the background. Very, very simple. Each stain takes 20 seconds and a brief wash, and you're good to go. And the image quality is quite remarkable. This is, again, a normal breast lobule from the FIBI box. This is what the camera sees. And you can see the lobule on the left and the connective tissue and various blood vessels and capillaries on the right. And here's a bit of skin. The colors are different, but they can be, that's just how the camera was set up. But these can be converted to look just like H&E, just as we can do with Muse if you want. The structures are very nicely presented here. The other nice thing is that it's better than H&E in many different ways. It has different contrast so that you can see things that are normally all pink on H&E, hematoxin and eosin. But because there's fluorescence going on as well, you get some of the bonus information from tissue fluorescence. And so on the left this is a sarcoma, connective tissue, malignant tumor. And there's a lot of pink. The tumor is kind of the top left of that pink area, but then a lot of the other pink stuff is collagen, but it's all pink. And on the right, you can see the tumor cells here orange, but the collagen is very easy to discriminate the connective tissue in the kind of light blue. And so this makes life much, much easier for people trying to just figure out what's going on with tissues that would otherwise look very, very similar. Remarkably, you don't have to actually, many people have lots of paraffin blocks lying around and by the millions. And to do research on the stored specimens, you have to make slides from them, and then if you need to sort of look freshly at the tissue, but we can actually image the face of the block. So this is a oral squamous cell carcinoma. The tissue is still in the wax. We just get rid of a little bit of the wax at the surface. We image it. We get nice histology, and then the tissue can go back in storage, essentially none the worse for wear. And there's also, as I mentioned before, lots of colors. I showed you the lots of colors in Muse, but there are also lots of colors in FIBI because we're combining absorbance and fluorescence at the same time. And so we're comparing the same blood vessel. Here is the slide made of that blood vessel, H&E. It's pink. And here's the same blood vessel before making the slide. And so now you can look at the walls. The walls have 4 or 5 or 6 layers in them, depending on what kind of, how much coffee I've had in that morning. Over here on the left, the wall is basically pink. You don't see any of that structure. So there's potentially new biology, new pathology waiting for us to learn from because we can now see things that we haven't seen before. And here's another example now looking not just at colors, but also structures. Because the tissue is thick, we can see a little bit more of it, like I showed you with the, as I showed you with the blood vessels in that Muse image of the fresh lung. Here, if we're looking at cat small bowel, and these are the villi on a thin slide of, these are the structures that absorb food in your gut. And if you looked at this, you'd say to me, oh, villi are little round ovals floating in space. Of course, that's not true. They're fingers projecting from the inside. And with with FIBI, because we're looking at a thick piece of tissue, we haven't actually sectioned them and we can see them in their entirety. And so there's a way of seeing more about the tissue. And this, I think, is going to be very important in breast. Here's an example in breast, because some of the structures that are really obliterated when you make thin sections are visible when you look at thicker specimen, the surface of thicker specimens. So this is an exact comparison. On the left is H&E, on the right is Phoebe. This little sort of blue blob at the top, in the top, that's a bit of a tumor deposit. And on the bottom, you can see blood vessels surrounding or near the tumor. And on this yellow star identifies the same blood vessel. But if you look on the left, you can see that blood vessel, but it's very hard to see any other blood vessels. And if you look on the right, you can see that blood vessel, and then all of the capillaries as well. And there's an awful lot of new research going on about the importance of blood vessel structure in defining and or reflecting tumor properties. And so on the left, you can't see them. On the right, you can. And we're actually starting to do some nice studies, I hope, on the mathematics of blood vessel organization. So finally, it's our wonderful pleasure and good fortune to be working with Dr. Wafia Dai, who runs the Peace and Love Hospital, who founded and runs the Peace and Love Hospital breast cancer treatment in Ghana. And my colleague is shown there, Eric Seibel, who helped develop and build the physical instruments that have been shipped there. And you can see down at the bottom at low power, one early example of one of the cores that were acquired and imaged immediately in the box that I'll show you in the next slide. So there's there's Beatrice and Mr. Fowler, who is actually the engineer, a wonderful optical engineer in Dr. Seibel's laboratory, who helped build and ship and install the box in Ghana, and it worked right away, which is wonderful. And that's shown here. He's about to ship generation 2, which has a 20x instead of a 10x lens and less vibration. And so I think we're just about to start to acquire his clinical grade quality images for patient evaluation, and ultimately patient care in Ghana and hopefully around the world. Now, all right, so that's that whole story, why we developed this rapid technique and how it might be useful in various settings. And just one other thing, we're trying to add to its capabilities because, as I mentioned before, typically what people do is not only do the histology, but they also try to do some level of immuno characterization. What molecules is the tumor expressing? And so we're working with Anvita Gupta here in near Sacramento on some new ways of actually staining and viewing molecular markers and the things that you want to, and ideally we'd be able to do it on the same microscope with the same inexpensive equipment. Typically, when people look at fluorescence microscopy, they have to use sort of fancy, expensive fluorescence scopes. We want to use the same scope for not just the histology, but also the imaging of molecular markers. And we would also like to get away from antibodies, which can be expensive and can be unstable. They're large proteins, and so they need to be kept frozen or freeze-dried. And so Anvita has developed some tiny 10 times smaller molecules that act like antibodies, and then we're coupling them with some very, very bright fluors that are shelf-stable and don't bleach, photo-bleach. And so hopefully these will be reagents that can be easily transported and used throughout the world. So as I mentioned, or you heard, we did train pigeons previously to diagnose breast cancer. And here's a pigeon looking at an image, just like I trained you to do. And it has to decide whether it's cancer or not cancer. So it pecks the blue bar or the yellow bar. And if it gets it right, it turns around and gets rewarded with a treat. And we've learned from that. That's how we now train our residents. If they get the right diagnosis, we give them a treat and they learn quickly. That's not exactly true. So this is what we call AI. This is avian intelligence. And which brings me to the point that I forgot to mention at all anything about AI up till now. But I think you all are familiar with it. You don't need me to tell you about it. It's an amazing, rapidly developing field. And all of the images that I've been showing you are have been and are sort of perfect inputs into AI interpretation, so that you don't have to worry about whether the pathologist is there in the room reading the images. The images can be, which are digital, that we make, can be popped up into into the web and sent anywhere around the world, or simply diagnosed immediately with a box next to the microscope with an AI tool. So all of that's for the future, but you can see how this can evolve and address not only the shortage from our technique, that shortage of people to make the slides, but also a worldwide shortage of people to interpret the slides. So that's the AI coming. So there's the pigeon. And as I mentioned to you, Muse Microscopy had a big booth at ASCO. And this is literally someone saw a pigeon walk by that and took this picture. So two themes from my life have converged here, which I think is cute. And I'm going to conclude by telling you that it is happily, pathology is no longer just a 19th century discipline. We're moving along, and we and other people in the field have developed new tools, which hopefully will be equally useful in both high and low resource settings. And I'm looking forward very much to see what happens. That's our dog Maggie. She's also very curious. That's a wonderful image. Looks like something from the Hubble Space Telescope, but that's a breast imaged with Muse. And this is just a sort of random sampling of the people who've helped along the way to make this actually happen. And that's another one of our animals. That's Toby, who's asking if you have any questions. I'd be happy to address that to you. Thank you very much.
Thank you so much. Oh, this is wonderful. Richard, really excited to see, how you have developed this, and not only developed this, but, with this amazing vision to get this globally, right? Really transforming the way that we do pathology. And I think there's a tremendous opportunity for, low and middle income countries to actually leapfrog, from, not even having, some of these technologies to now being able to have pigeons interpret, some of these things.
Yes. They're inexpensive, and they
Yeah.
function well unless they're laying eggs, it turns out.
Yeah, there'll be some great questions coming in the chat. Saif,
Sure.
do you want to read these questions for?
Please.
Yeah, I can go ahead. Thank you for your great lecture, Dr. Levinson. So we have a few questions in the chat. The first one is, how are Muse microscopy on your phone images interpreted using AI, or do they need a pathologist?
Well, I think I addressed that at the end. First of all, I don't know if the phone microscope that I showed you, that one literally is going to be used. My colleague who developed it sort of stopped developing it because it was too hard to keep track of new iPhones every year or two, and everything, the physics changes, the physical components of the lens change every year. But that basic point is that it is possible, if you sort of set your mind to it, to develop a very, very inexpensive box that could be used, much less expensive than the box that we developed, because our box has very high-end lenses, XYZ stage, fancy camera, computer inside. I think my point to show you the cell phone version is to show you that there really is no fundamental obstacle to making these things extremely affordable. And as I mentioned, AI, there can be a pathologist in the room. There can even be a trained non-pathologist in the room, or we can certainly in a year or two start relying very heavily on AI to help.
Great. The next question is, how could the integration of real-time high-resolution microscopy into biopsy procedures revolutionize breast cancer diagnosis? And is it possible to achieve accurate diagnosis without removing tissue in the future?
That's a very good question. That's sort of the cleavage there is between ex vivo diagnostics and in vivo diagnostics, or in situ. In other words, And there's sort of two settings for, so ex vivo means outside of the body. What I've shown you, biopsies, needle biopsies, even fine needle aspirations are all happening ex vivo. In vivo means you sort of stick a needle or an endoscope or something into a patient, and without removing tissue, you examine what's there. And there's a huge amount of work being done with that, especially with GI tumors and endoscopes or things for, sigmoidoscopes, things that go up the rectum. And you can, if the tumor is visible on or near the surface, you can do an awful lot of work with various different technologies. In fact, I'm working with on one of those right now with the guy who invented them at Emory. Dr. Robles, and I just have to say the name of the technology because it sounds intimidating. It's quantitative oblique back illumination microscopy, which sounds daunting, but actually you can do it just with an LED and a lens and a camera. And that looks very promising. Or you can have needle-based microscopes where you put the needle in and then it sort of looks around itself to see what's going on. And those are looking very promising as well. Of course, you're sampling a tiny area. And then there are situations where it's not so much diagnostic, but you're trying to do surgical guidance, where the surgeon is in there taking the breast lesion out, and they very much want to know when they do cut the lesion out whether there's residual tumor still in the patient or not, and so they image the cut surface inside the patient to see if they can see tumor there. So that's more in vivo imaging, and people are doing that with confocal microscopy, with multiphoton, with photoacoustics, or with QOBM, the one I just mentioned. And there's a grant that I'm on being reviewed or just been submitted to do that for brain cancer. Hope that answers the question.
Yes, I think it does. Another follow or similar question, I guess, is it possible that future imaging technologies will allow real-time assessment of the physiological and pathological states of microcells in vivo?
What I've shown you are techniques, not necessarily because we do rely on stains, but there are other techniques that use wavelengths at different ranges or different absorbances, which can actually detect in vivo metabolites like NAD, NADH, other things that reflect the energetics of the cells. And I'm not an expert in those, but I'm saying that there are complex ways of getting more information about the biology and the metabolism of tissues in the body, without taking a biopsy.
Another question is, how much does this technology cost, technology such as Muse?
Well, as I sort of mentioned, if you put it on a cell phone, it's $20 plus a cell phone. The boxes that are being implemented are in the tens of thousands, and there's significant sort of physical costs to get a nice stage that moves reliably X, Y, and Z. Good quality lenses cost several hundred to several $1,000s. Cameras can be in the $1,000 range. So, but all of these can be compressed down, and if you put your mind to it, you can get these probably at least equipment costs under $10,000. And then, of course, what does it cost to sell and maintain and have a profitable company? And companies need to make profits. So, in well-resourced settings, we're talking $20,000 or $50,000 a box, which is still a lot less than some of the other techniques that I've mentioned, which are up in the $100,000 range.
Got it. Another question. So the use of AI in pathology is dependent on existing digital repositories of slides for training. So how do we work around this, especially in resource-limited settings, especially with the advent of data protection acts that may prevent sharing of data?
A very excellent question. One of the fortunate things about our techniques is that they are so close to standard histology that it turns out that I was able to take one of our images otherwise unprocessed and submit them to an AI tool that was developed in Dr. Faisal Mahmood, who's actually a collaborator of ours. His system, which has been trained on hundreds of thousands, if not millions of slides, and of digital standard H&E stained slides. And his box, without any prompting or any other treatment or fiddling with, was able to diagnose our specimens immediately. So as long as you're pretty close, you can either use the current AI tools directly, or you can do things called transfer learning, where you take the benefit of thousands or millions of slides, and then you fiddle it a little just to be able to use all of that embedded experience and information, and then either you change the appearance of our slides to look more like H&E, or you change the AI so that it can handle our, when I say our, but these new technique slides without too much training. So we're sort of almost ready to go. The more different techniques like optical coherence tomography or other things which are really a long way away from standard histology, that's going to take their own training. And in terms of image security and HIPAA protection and other things, that's very much an addressable problem. You can actually just train locally, or you can, there are techniques of taking your own images and stripping away all of the HIPAA information and then sharing them with other sites in essentially an anonymized fashion to help training. There's a sort of whole class of stuff called federated learning, where you can have one box that is learning on multiple different information from multiple different sites around the world, but each site doesn't give up the learning takes place locally, but the knowledge is shared globally. If that makes sense.
Sounds great. Two questions left. What do you see as the key limitations in terms of data quality, interpretability, and clinical integration of AI in pathology?
Well, that's AI, and not necessarily what we're doing. It's obviously a rapidly moving field, and people are beginning to look very critically at the excuse me, at the pluses and minuses and the dangers of AI, and it has to do with an awful lot with differences between centers or data sources. As I'm sure many of you know, the breast cancer in the US is very different from the breast cancer in West Africa. We use the same terminology, but the molecular underpinning, the prognosis, the family histories are different. And so a technique, not really AI, but sort of trained on multiple immunostains called Oncotype DX, which is widely used to look at various genetic or molecular markers and predict breast cancer outcomes. It works quite well in the US, and it fails abysmally in West Africa because the biology is different. So it is crucial that the AI tools be trained on the populations that you're actually addressing. Apart from that, I'm just very, very confident that the field as a whole is going to become ever more capable. And don't forget, we humans are becoming less capable every year. As we rely more on these tools, we will actually, our training and our sense of autonomy is naturally going to diminish over time. And so we really will have no choice but to work with AI in the future. And as an example, you're all familiar, I use GPS to get around town. If my iPhone broke, I might be downtown Sacramento and I could never get home because I don't know how to get home from Sacramento to Davis without the help of, certainly parts of it, without the help of my iPhone. And that's going to happen across human knowledge, I'm afraid.
Great analogy with the GPS. And then the last question, why did you choose pigeons specifically for image interpretation? And how do you train the pigeons?
Excellent question. So I chose pigeons because I was driving to work one day. I live in Davis, but the hospital is in Sacramento, so it's about a 20-minute drive straight down the highway so I can think about things. And I was listening to the radio, and someone said, describing just some research at UC Davis, that they were using pigeons to look at image recall. And I said to myself, image recall, that's what pathologists do. We recall images, and we take what we've learned and we apply those thoughts to the new image that we're seeing under the microscope. And I called and I said, why don't we see if the pigeons can do that? And I called the guy up, and he said, oh, great idea, but don't talk to me. Talk to Ed Wasserman at University of Iowa, who actually ran the pigeon experiments. And I called up Ed, and he thought it was a great idea. And so we did the research in Iowa. And quite honestly, and I'm ashamed to say this, I have actually physically never met Dr. Wasserman, and I've never met the pigeons. But it turns out that pigeons are a very, very well used tool in psychology research because they're easy to maintain, and homing pigeons have remarkable mental skills which involve an awful lot of image recognition because they have to fly through the air, navigating by looking down on the ground, and that's really what we do. When we look at a slide, we're flying through the air, looking down on the ground and trying to figure out where we are. So basically to train them, you would give them an image and ask them to pick either yellow or blue. Yellow, and we would switch the meanings of yellow and blue so there's no bias there. And if today yellow meant cancer and it picked yellow, we would reward them. And they went from 50%, in other words, completely chance on day one, to 70 or 80% accurate by the end of 1 week of training, and up to 85, 90% later. And if you let 4 pigeons vote in a process that we called flock sourcing, they were 99% accurate. So it's pretty frightening. So we're being threatened by AI on both fronts.
All right. Thank you, Dr. Levinson, for inspiring with the possibilities of pathology to advance global health. We're excited to carry forward what we've learned today. Thank you, everyone, for all your attendance and participation. If we don't have any more questions, I think we can go ahead and conclude today's session.
Yes, thank you so much, Richard. I really enjoy this. I think we need to disseminate this like widely. I know we have many people who are registered for this course. So I think even just beyond Africa, with Ghana that you're working with, I think this is a technology that so many places can benefit from. And I think we need to really disseminate this widely. And I think the challenge would be, how can we really democratize this? What will it take for us to democratize this? I just think that this is going to be very transformative with high impact. So something that I think we'd love to continue to work with you on to see how, we can democratize this technology. And just amazing with the pigeons. It's a, I think it by itself should be a TED Talk, I think.
Yes. I was in the running for an Ig Nobel Prize, and I think I was robbed. I should have gotten an Ig Nobel for that.
Oh, yeah.
All right.
Yeah.
Well, thank you so much. It was a real pleasure.
Thank you so much. Yes. All right. Bye. Have a good weekend. Thanks.